All right. Are we ready to go?
We're ready to go.
Okay, great. All right. So tonight we're going to talk about the intersection between endometriosis, MCAS or mast cell activation syndrome, POTS, postural orthostatic tachycardia syndrome, and I'm using POTS as sort of a general representation of dysautonomia, kind of the challenges in the conversation between the autonomic nervous system and the rest of the body, but particularly the cardiovascular system and perimenopause. And anything you want to learn more about our institute, you can find at integrativewomenshealthinstitute.com. So, what our program, we now teach a kind of a year-long deep dive program in perimenopause and menopause transition, but integrated with complex chronic illness. Because the reality is, we think complex chronic illness and it seems so rare, but the reality is that women in the perimenopause transition, roughly between the ages of 35 and 55, 87% of us have some other complex chronic condition that we're navigating at the same time. That's either triggered during the perimenopause transition because of the hormonal shifts of perimenopause, or is pre-existing, or just happens to arise at roughly the same time. And so, what we're going to talk about is how perimenopause amplifies endometriosis, MCAS, and POTS through hormonal, immune, and autonomic mechanisms. We're going to distinguish some overlapping symptom clusters across these four conditions. We're going to apply the Integrative Women's Health Institute assessment and intervention sequencing framework for this complex multi-system presentation, and I'll do that within a case study. And then we'll talk about identifying red flags and scope appropriate actions across practitioner disciplines, depending on what kind of practitioner you are. So, just to introduce how this might show up in your practice, meet Maya. She's 44 years old. She was diagnosed with endometriosis at age 29. It was managed for 10 years post excision surgery with nutrition, physical therapy, and occasional NSAIDs, and was fine. She was managed very well. But over the last 18 months, she's having more variability in her menstrual cycle, heavier bleeding, and a few irregular cycles. She had a mild COVID infection in that 18-month window. It was her second since 2021. She has new food reactions that she never had before. She has increased dizziness on standing with racing heart, tachycardia, difficulty exercising without a very high elevated heart rate. She often feels worse the day after exercise. She has worsening fatigue that doesn't respond well to sleep. She has difficulty falling asleep. She feels more reactive to heat, perfume, stress, and exercise. She has increased bladder pain and sensitivity symptoms that she states were more like before her surgery. She has been navigating grief since her mother's early stage dementia diagnosis 6 months ago. And she has an 11-year-old son who's been struggling as he's beginning middle school. So, perimenopause doesn't tend to cause these overlapping and complex conditions, but it very often amplifies them or sort of unveils them. Women whose disease, dysfunction, and symptoms were managed for many, many years can hit the perimenopause hormone transition and then other stressors simultaneously, because the perimenopause transition is roughly 10 to 15 years, tend to then women have less resilience, particularly less metabolic resilience at this time. So in perimenopause, there's not this like steady decline of estrogen over the years. In fact, day to day, estrogen levels in perimenopause can be literally all over the board. They can be quite high, they can be very low, but it's highly variable. And elevations in estrogen can actually trigger mast cell degeneration. And sensitivity. So what are the mast cells? Mast cells are immune cells that are supposed to be reactive against invaders. They release histamines and other inflammatory cytokines. But, when they're exposed to gluten or dust or heat, they should be fine. And in people with endometriosis overlapped with mast cell sensitivity and mast cell activation, often the moments, which could be cyclical, they could be any random time during perimenopause, particularly when estrogen is relatively high and progesterone is relatively low, mast cells are more sensitive and more likely to degranulate and then release symptoms of mast cell activation. Now, those symptoms can look like a number of different things. They can look like rashes, they can look like hives, they can look like severe sensitivity to bug bites, they can look like bladder pain syndrome. It's a lot of, when I hear the words burning pain, I immediately think mast cell activation. So itching, burning, sensitivity, and even anaphylactic reactions. But prostaglandins are among the cytokines that can be released. And so mast cell activation syndrome is often quite painful. And again, it could be anywhere, could be organ pain, could be nerve pain, could be vascular pain. So in perimenopause, estrogen is literally all over the place day to day. Progesterone declines more kind of in an overarching gradual way through those years. But this loss of progesterone, so again, over time, you're losing progesterone and its relationship to estrogen is still going to be highly variable because estrogen is highly variable in this time frame. One of the great benefits of progesterone is that it supports GABA production in the brain. One of its metabolites supports GABA production in the brain. And GABA is a calming neurotransmitter. When you lose that calm, the nervous system begins to be less calm from an autonomic perspective, less parasympathetic, and thus it can be harder to regulate blood pressure, heart rate, breathing rate, cranial perfusion, so perfusion of the brain, which can, of course, if someone's walking around with not enough oxygenation to the brain because of the lungs or because of the blood flow or because of the blood pressure, anxiety and sleep disorders can occur. We also generally see sleep collapse because of this change in progesterone, but also, other things can irritate the sleep cycle in perimenopause, such as hot flashes and night sweats overnight, which will then reduce the body's primary recovery window, reducing the overall resilience and amplifying these symptoms from all of this. So you get, with estrogen flux, you get some days where estrogen is low and a person is more prone to insulin resistance. You get other days where estrogen is high and they are more prone to mast cell degranulation. Over time, we have progesterone loss, which reduces that ability of nice, stable GABA and the nervous system feeling calm and regulated, and then lack of overnight recovery night after night. So estrogen, while it's primarily known for its role in reproduction, estrogen can impact, it does impact hundreds of receptors across the body. Now, we know now from some of the data back in 2018 that endometriotic lesions can respond both to estrogen and progesterone, depending on which receptors are upregulated, sometimes both, sometimes neither, sometimes one or the other. But generally, these ectopic lesions show a relative estrogen receptor beta overexpression and interaction with TNF alpha and reduced estrogen receptor alpha, with both receptors contributing to lesion growth, proliferation, and inflammation under estradiol stimulation. So it's not to say that estrogen always causes or irritates endometriosis lesions, but it certainly can in some women and some lesions, which, as the estrogen levels are highly variable and fluctuating, that can impact the activity of some lesions. And there isn't really a very simple way to know which lesions, which women, like exactly how this is impacting any given woman. But it's something to consider for women who have endometriosis, who maybe, for example, maybe considering hormone therapies, which at some level may be helpful to stabilize estrogen levels, at some level may be irritating. So, this is one of those things that we really have to be mindful as we help women use different tools of any kind of hormonal modulation. Mast cells, as I mentioned, express estrogen receptors, and physiologic concentrations of estradiol can directly trigger a partial mast cell degranulation and even an IgE, which is like a purely allergic mediated release of histamine associated mediators and estrogen receptor alpha signaling. So, again, during perimenopause, when there's high fluctuation of estrogen, generally declining progesterone, mast cells can become more active. So, you're looking for allergic like reactions, could be even anaphylactic reactions, burning pain, sensitivities, rashes, skin issues, bladder pain, vulvodynia, all of that. And then estrogen modulates vascular tone directly. And it directly modulates autonomic activity. So when that loss of when a woman, say, for example, just goes from sitting to standing, no longer has the appropriate response automatically of vascular tone, she can be lightheaded, dizzy. She can have low blood pressure. She can have high blood pressure. She can have heart rate changes. I like to describe it, having experienced POTS for the last 6 years or so. It's like you go from having an automatic transmission in your body where you just you stand up, you don't think about it, to manual. Like you have to be very thoughtful about how you move, when you move, what kind of movement, because your body doesn't automatically respond to movement, to heat, things like that. So it'll be harder in a shower, nights it gets hotter when you're exercise under super hot or super cold conditions, things like that. So this, I think, gives us just some idea. This is, not particularly to scale, but it's not at all to scale. But you can see that in perimenopause, the estrogen and progesterone are just all over the place. And so in some ways, and for many women actually, once they hit post-menopause, their estrogen progesterone levels, while lower, and again, in many women will support these with medical hormone therapies, but they're much more stable over time. So often women will feel a lot better in menopause compared to perimenopause. But also notice these are all these different G protein coupled estrogen receptors literally everywhere. So it impacts the vascular system, impacts cardiac contractility, impacts the the thymus, the thyroid, the immune system, obviously the bones. We know a lot about osteoporosis is being impacted by estrogen. So even skeletal muscle contractility and exercise intolerance. And so when we think about estrogen, we want to think about it in its relationship to the full body, not just the reproductive organs. So endometriosis, as we all know here, is a systemic neuroinflammatory condition. And so thus, everything that impacts estrogen is going, and the impacts of estrogen to the nervous system, the immune system, and the metabolic system will impact endometriosis. So one thing I really wanted to mention, because I think it's so important, and literally no one is talking about this, even though yesterday was Long COVID Awareness Day. I mean, long COVID is so incredibly common, and it's increasing rapidly year by year. And among the groups absolutely most at risk are women with endometriosis who are in perimenopause. Also menopause, but perimenopause is slightly higher risk. So we're in a continuing COVID pandemic, as we all know. And there's this hormone fluctuation of perimenopause. In women with endometriosis, there's about a 41% higher risk of getting long COVID compared to men with any given infection. And also, women in perimenopause have a 27 to 45% higher risk of long COVID. It's about 43% higher in menopause. And the other issue is that the risk of long COVID is cumulative with each infection, particularly if these infections are relatively close together, because it takes at least 6 to 24 months, even from an asymptomatic infection that people feel like they've recovered from, to actually recover the brain, the immune system, and the vascular system, even with absolutely no symptoms. In fact, 80% of people with long COVID don't even know they have it, and they are asymptomatic based on some data out of Mount Sinai. So the reality is that while we keep talking about all these, why is perimenopause so bad now? The reality is a lot of these women have long COVID and they just don't know it. And the symptom profile is somewhat similar. But of course, the treatment isn't, medical hormone therapy doesn't solve the entire problem. So, for example, a couple of weeks ago when I was finalizing these slides, you can keep track of kind of how common COVID is at any given time. At this website, people are still tracking wastewater data. That's the most accurate. But as of February 2026, 1.7% of the US population was infectious. Cumulative infections on average per person in the United States, roughly by now, about 5 infections. So any given infection, your average person has at least 40% increased risk, and that increases a lot more with women in perimenopause with endometriosis. So if we think about the combination of the physiology between endometriosis and perimenopause, endometriotic lesions are, for the most part, impacted by hormonal changes, although it's not a very clear one-to-one impact. We don't know exactly in each person how each lesion is going to respond because there's no way to test that individual lesion by lesion until they're removed. So these impacts can be driven by estrogen, progesterone, both or neither. And then you have this general chronic neuroinflammation and cytokine load, which is exacerbated by stress, everything from caregiving, financial, nutrient deficiencies, infections, too much sugar, like any number of things. And what 45 to 40, to 52-year-old woman doesn't have these things, right? Local nerve sensitization and central sensitization exacerbated by stress, mast cell activation and immune dysregulation, which will often co-present with autoimmune disease, and pelvic floor neuromusculoskeletal and fascial dysfunction. So again, looking at these interactions with COVID, knowing that COVID is still extremely common. So here's like when, what we used to call during the pandemic, but the reality is while, there was 1 month in 2022 that had massively high numbers, the numbers in 2026 are actually higher than they were in 2021. So, and then the more infections you've had, the higher the risk. So when we think about that, when we think about the symptoms of endometriosis, chronic pelvic pain and dysmenorrhea, dyspareunia, bowel and bladder pain, IBS-like symptoms, migraines, headaches, joint and myofascial pain, food sensitivities, environmental sensitivities, fatigue, low energy, infertility, pain flares, and then the overlapping conditions that are commonly present in endometriosis and were commonly present prior to the pandemic and in women who are not perimenopausal, who are just premenopausal, MCAS, POTS, hypermobility syndrome, various hypermobility syndromes, digestive dysfunction, gut dysbiosis, immune dysfunction, neurologic dysfunction. So the challenge here is that distinguishing endometriosis specific flares from overlapping conditions is challenging, right? Because MCAS triggers bladder pain. Endometriosis, bowel sensitivity can trigger dizziness. So can POTS. People with HEDS are at higher risks of MCAS, POTS, and endometriosis. So instead of thinking about like, are we like treating endometriosis? Are we treating MCAS? We want to be thinking about this perspective of the upward spiral of healing. We're just doing everything we can to improve the resilience of the neuromusculoskeletal system, of the autonomic nervous system, of the immune system, and of the gut microbiome. And when you look and the metabolic syndrome system, and when you do that, you begin to see an expansion of tolerance over time while we're progressing, tolerance and resilience while we progress slowly. And we have to do that because women with endometriosis, with HEDS, with MCAS, with POTS, and very commonly long COVID, which presents as MCAS, POTS, organ dysfunction. We can get into some of the other details of that, vascular dysfunction. When you layer on top of that a really heavy allostatic load, such as variability in these symptoms through the menstrual cycle, lowered resilience to stress, changes to diet and exercise, poor sleep, lack of recovery, sensitivity to foods, to supplements, to medications, allergic to everything from, bug bites to gluten, you begin to, have to start with really small, gentle changes at the beginning to just build a little bit more resilience in the system. So I think everyone here knows that it's a myth that endo just gets better after menopause, not necessarily. And perimenopause can certainly increase the symptoms, especially with repeat COVID infections, or by the way, any other infectious history, because COVID tends to reactivate any kind of chronic viruses that had even been, in remission, things like EBV, cytomegalovirus, Lyme, et cetera. And it sets you up because it changes your immune system again for roughly between 3 and 24 months is the current data to lower T cells. So it's a little bit like HIV in that regard, in that, for example, if we think about the last couple of years, right? People have had rare forms of pneumonia all of a sudden last winter. The winter before, we had, this heavy, these high numbers of norovirus. And this is coming because people's immune systems have been damaged by COVID temporarily or permanently, depending on the severity. So again, we have this hormonal fluctuation, which will impact with general inflammation, both in the brain and nervous system and at the level of the endometriosis lesion itself. Heavy irregular bleeding worsens fatigue and iron deficiency, which is already a significant burden. Menopause may not suppress symptoms if residual lesions remain and are hormonally active, particularly if we're adding hormone therapies. That may help, that may not help. And certainly immune dysregulation will persist unless it's addressed. And then again, I really believe, most of our patients, and I work with a nurse practitioner who does prescribe hormone therapies. Most of our patients in their 40s with endometriosis eventually do well with carefully dosed and monitored medical hormone therapies to protect all the other things that estrogen and progesterone are super valuable for. But we have to be really mindful because sometimes the endometriosis pain can come back, but it's this real balance between, hot flashes, night sweats, sleep issues, bone loss, libido challenges, brain health and brain focus, neuroinflammation, metabolic health. And a lot of these can be really well supported with medical hormone therapies, but in a presentation where someone also has endo, MCAS, POTS, we have to do this really slowly and first with like a floor of resilience to make sure that, adding even just one hormone therapy at a very small dose isn't going to trigger a cascade of problems. All right, so around here, and I think in other places too, this is called the triad. Um, Ehlers-Danlos, hypermobile Ehlers-Danlos, or any hypermobility syndrome, or even genetics that predispose POTS and MCAS. So if we think about this triad, these things often co-present. And again, another really strong risk factor of long COVID is having any genetics, even like the smallest single, SNP for any hypermobility syndrome will increase that risk and will often, again, unmask hypermobility symptoms that did not present pre-COVID. So this is connective tissue laxity affecting every system, not just the joints, but also the gut. So things like gut motility and also things like the vascular system, depending on which genetics are impacted in hypermobility. So imagine someone has, floppy, if you will, vascular system and dysautonomia, really, really hard to quickly stand up and have perfusion of oxygenation to the brain, especially if they also have long COVID, which comes with microclotting and difficulty transferring oxygen from the vascular system to the cells and tissues, particularly the muscles. Then this person's trying to exercise. Maybe they can power through it, but boom, they are going to crash for days. And that could also trigger their mast cell activation. So that crash could come with a lot of pain, a lot of deep fatigue, a lot of burning, even kind of hives and rashiness. So when you think about the combination of connective tissue laxity, even if it's not vascular directly, it might be just the, fascia and myofascial connective tissue, then you have that laxity, which makes it really challenging for the autonomic nervous system to adapt quickly. And then if they also have POTS, it's a real challenge. That can trigger the mast cell mediators, triggering inflammation and continuously irritating dysautonomia, overlapping genetics. There are some genetic mutations that trigger kind of all of this triad. And then SARS-CoV-2, Lyme, EBV, and other infections, flu, can unmask or worsen or trigger this triad. So when you think about this in perimenopause, you also have on top of that difficulty regulating temperature, hot flashes, night sweats, the loss of estrogen, which supports the metabolic floor. Estrogen is critical for collagen and bone integrity, which really helps the structural stability, which if we're losing that, it's going to make the HEDS present even worse. And so you can see that this is like a negative downward spiral. So we want to be thinking about how can we build up more and more and more resilience in this system. So here's kind of the some of the various ways that these issues really interact with each other. So, for example, quercetin is something we can use in both mast cell activation syndrome and endometriosis related inflammation. It's an anti-inflammatory, but it also quenches histamine. So when we're thinking about building reserves, how can we add some things that help stabilize across these various issues? So, when you're working with this as a physical therapist, occupational therapist, nutritionist, physician, you want to think about how can you build a really strong team to help people navigate these things, because usually these 3, 4, 5 issues, can come with other issues. One can be more dominant than the other. Someone's cardiovascular issues may be their big driver right in the moment. Other times, they may be dealing with a lot of really problematic allergies or burning pain. So we might want to have different specialists on the team and help people think more like in a scatter plot, right? Like what is all involved in this and how can we build a team to really support the whole system? Now, we've created these tools that we call the maps, which kind of help walk you through a framework for this. And I'm happy to share some of those. I'll figure out with Sally how you can get that. But basically, it's just like what are some of the assessment tools? What are some of the things we put them together in the maps? And so the two that we're going to talk about today cover the intersection between the triad and endometriosis and generalized pain and inflammation. There's not a perfect way to divide all these things up because, as we just talked about, many of these things co-present. But looking at these two, here are some of the assessments that I think could be particularly valuable. First of all, you want to see if they're presenting with signs of hypermobility. If you have genetic testing, that's great. If not, for looking at POTS or dysautonomia, really basic in the office. How does the blood pressure and heart rate change with sit to stand, with activities? Wearables over time can be useful for trends. Standing for 10 minutes is a standardized test called the 10-minute stand test to rule out POTS or rule in POTS, get curious about POTS. And then another compass, the Compass 31 questionnaire is helpful for autonomic function. With mast cell, there is some testing you can do, like 24-hour histamine and prostaglandin testing in the urine. You can look at tryptase testing, but that's only going to be particularly accurate when someone is flaring. Food, environmental triggers, but a lot of times, obviously starting with symptoms and flare logs, I mean, it's like a blaring red flag to me if someone has rashes in multiple spots, if they have hives, if this starts during times when they're exposed to things like environmental factors and like I said, burning is like the telltale sign, whether it's bladder burning or vulva burning or whole body burning. And then one of the things that can be really valuable working with your physician colleagues is testing H1 and H2 blockers, which you can get over the counter, things like H2 blocking acid reducing medications or allergy medications that will block histamine receptors both in the gut and systemically. If people feel a little bit better on these, that's a big positive sign. But there are better tools. These are useful tools, but there are even better tools. Also looking at iron, CBC, B12, thyroid panel, particularly if they're very fatigued. Fatigue goes along with this, as you can imagine, right? The person used to be automatic and now they're manual. That takes a lot of energy. So, looking for other causes of fatigue like anemia or thyroid dysfunction or autoimmune thyroid disease. Dutch for hormone mapping can be helpful. There's also a tool called the MIRA, which is a urine test that kind of tests hormones day to day. This is not required for hormone prescription, but it can be helpful, Dutch. And I actually prefer the MIRA now. We've been using that more in practice because it's like a day to day looking at what your levels of FSH, LH, estradiol, and progesterone, because when you're doing some tests of the hormone levels, sometimes it's helpful if they're done at certain times of the month, but it's really about in relationship to ovulation. And in perimenopause, of course, ovulation can be any time in that cycle. It could be no time in that cycle. So just doing it by counting days isn't going to be very accurate. I also like stool testing. I think it can be really valuable because at the end of the day, one of the core drivers of both endometriosis and MCAS and POTS is immune dysregulation. And so the more we can optimize the interface between the gut and the immune system and improve immune signaling at the level of the gut, BiomeFX is a good test. It's a stool test, which looks more functionally at the gut to see, like, even if you're lacking certain gut species, you may not need to add those back in with probiotics necessarily, because the gut microbiome does have a lot of redundancy. There are other good tests like GI map, for example. Tiny Health is another good one. And then, again, looking at formal diagnoses based on genetics, cardiology becomes really important in this phase because women in perimenopause are at higher risk for cardiovascular disease. And particularly because in women, our heart attacks are different, and they're more often caused by arrhythmias, which will, of course, potentially be triggered by dysautonomia and or low estrogen, immunology for mast cell conformation, and of course pelvic PT. So I like to think of this in sort of a pyramid. So where are we going to start? And for 20 years, I've been saying don't chase symptoms, optimize systems, particularly when we have clouds of symptoms like this. So how regulated is this client's nervous system? And this can be really hard, in this time of life and also this environment that we're all living in. Tracking heart rate variability is the one tool. And in our practice, especially with clients with endometriosis and perimenopause, we usually use a Garmin tracker because it's less expensive than many of the other ones. It gives you a general algorithmic look at stress. It can be just helpful for people to see what their body feels like when they're under stress. In my experience of working with tens of thousands of people with this kind of complex presentation, these women are really, really good at powering through their own stress. Like they really don't feel it very much. And so HRV tracking can help women see how resilient their autonomic nervous system is, or if they're really living in sympathetic upregulation all the time. And then we can do some things to support that, as simple as magnesium, as bedtime routines, as more nature exposure, as, turning off the blue light at night when they're not in a lecture like this, adding progesterone. So many tools, even things like protein at consistent times during the day, a regular bedtime, a regular wake up time. We have so many tools. Then we also have things like Tai Chi, Qigong, breath work, movement, you know, lots and lots of tools. And I don't like to give these in a checklist, like a person has to go home and meditate for 15 minutes a day. I'd like to really sit with my clients and think about like where and how are they maybe already using nervous system regulation? What are they using? What habits would they like to shift? Like little by little by little. And then we layer on things like hydration and sodium, particularly for those that have lack of central nervous system perfusion of blood flow and oxygenation. Fluid and sodium loading can be really helpful. Antihistamine diets can be really helpful, compression garments, and even just how someone exercises. Like before I got MCATs and POTS, I was a heavy strength trainer, heavy lifter, but for years I really couldn't exercise in standing, but I could exercise pretty well in parallel to kind of, obviously normalize the fluid and reduce the MCAS stimulation. And so Pilates, swimming, like there's a lot of other ways that we can modify exercise to keep that fluid flow perfusing the brain. Blood sugar and metabolic stability, again, everything from estrogen hormone therapies to have a stable floor under the perimenopausal shifts, anti-inflammatory lifestyle, protein, fiber, vitamin D, curcumin, omega-3 fatty acids. And there are ways to track continuous glucose monitoring to see if like blood sugar spikes or drops are triggering any of these symptoms in your clients. And then connective tissue strengthening. So, like, the more even proprioceptively that people feel more stable. So, exercise with Pilates, with swimming, with the CHOP dysautonomia protocol, keeping it hypermobility informed, not just at the level of the joints, but also the vascular system, this connective tissue, the soft tissues, vitamin C, collagen, creatine, just really adding support to the system. And strength training is really valuable here. It just has to be added, sometimes when some of these other layers are more stable. And then again, adding hormone therapies, either really mindfully, say to create a metabolic floor, or later when the MCAS is more stable, or maybe we're adding progesterone before estrogen in certain cases. It's very case by case, but these are the broad topics that we're thinking about. So, for example, we might do something like beginning fluid and sodium logging with an aim of 2 to 3 liters of fluid and 1 to 3 grams of sodium per day. Trial of light to heavier compression garments, see how that feels for people. And sometimes they just need it more proprioceptively. Other times they really do need true medical compression, connective tissue stability with both nutrition and exercise, strength training strategies. And then once they have more improved tolerance for standing or light daily activity, then we may see some symptom reduction with antihistamine eating, with hydration, and or things like quercetin, pycnogenol, which also helps with endometriosis pain, luteolin, ketotifen. So then we have some medical options, cromolyn sodium, GLP-1 agonists, which there are GLP-1 receptors on the mast cells. And there's some really interesting research happening right now there was a case series published about very low dose GLP-1s and mast cell activation syndrome with really positive results. And right now there's a big trial at Scripps looking at kind of the lowest prescription dose of tirzepatide, which is a combination of GLP-1 and GIP, in patients with long COVID related MCAS. So I'm really excited. I can't wait till we get the results of that. Then we start seeing, improved joint stability, improved exercise tolerance. For people who also have long COVID, they may also have ME/CFS. So if they are really fatigued or experiencing that post-exertional malaise, we need to be really careful with any kind of exercise. Even if the dysautonomia is dealt with, we have to watch their mitochondria. So if they are experiencing what's called post-exertional malaise, so either a couple of hours after or the next day, doing anything, could be just walking, could be light exercise, could be cognitive activity, and they're just like trashed or more tired than they were the day before, that's a big red flag that we have to go slower, and we have to really support the mitochondria and the probably look at blood clot issues or perfusion issues. Reduce MCAS flares with nutrition, environmental adjustments, or medications, pacing strategies to prevent post-exertional malaise. And then eventually we're going to see more predictable energy, less orthostatic intolerance. The client identifies individual triggers and effective counter strategies, improved digestive function and gut microbiome composition. And, just again, you see that spiral of improvement, improvement, improvement. So, depending on your scope, you're going to kind of step into different roles here. Health coaches and nutritionists, motivational interviewing, accountability, everyone has these kinds of roles. Anti-inflammatory and antihistamine eating is what I meant to put here. Dysautonomia exercise, core stability and strengthening for HEDS, pelvic floor assessment and treatment, fascial mobility, pacing, pacing, pacing. I cannot emphasize that enough. Over exercising people with long COVID related ME/CFS, which is often, part of this whole presentation, is a huge thing not to do. You can have people much, much worse to the point where they can be bedridden for months to years. So we have to be really, really careful of that. And, prescribing depending on what else they can do. So putting it together in this case, as a reminder, she had endometriosis excision surgery 10 years ago. She was stable with nutrition, PT, and occasional NSAIDs, but a lot has happened in the last 18 months that we're going to take a look at. So what systems are involved in her case? She's in perimenopause, immune mast cell activation, autonomic nervous system, POTS, connective tissue disorder, inflammatory, and then long COVID and viral reactivations. So we're going to assess all those different areas of the pyramid. then we want to think about the intervention sequence as more circular than linear. So, one thing that's really, really important, you take a person who has like all these issues going on. What is most important to her? What does health look and feel like to her? And that's really important because we have this idea that health and disease or disability are like a binary. But the reality is people are along a spectrum all the time throughout their lives. So what a next level of health really looks like to her is super valuable to help you organize what you're going to work on first. Then we want to, get the foundation set, sleep optimization, even basic sleep hygiene, HRV tracking, like how regulated is her nervous system. Hydration and electrolytes really, can make a huge difference. Something like slowly getting her up to 70 to 80 ounces of water a day and plenty of salty electrolytes. If she's dealing with POTS, that can really help her feel better because finally she's getting some blood to her brain. Antihistamine and anti-inflammatory nutrition, dysautonomia and stability movement. So she's gaining that structural fertility stability, but not in standing, where it's also really hard to perfuse the brain. If you're pushing that too hard, one of the clinical pearls you're going to see is what's called coat hanger pain. They're going to have a lot of pain kind of in the neck and upper traps and rhomboids. Literally, like if you were hanging someone by a coat hanger, that's exactly what it feels like. It feels like someone's like hanging you by a coat hanger, and it's a very ischemic kind of pain. HRT, MCAS stabilization. I really think people with this presentation have to have medications or at least supplements and nutrition on board to stabilize the mast cells in general and the immune system to be more tolerant before adding HRT, or that estrogen can really flare them. Same thing with POTS medications or strategies to make that system a little bit less manual. And then we're going to be reassessing what is endometriosis related pain, what are some of the other pain drivers. And then obviously referrals depending on the severity of different issues. Cardiology is a really big one in the perimenopause phase because with low estrogen, we have higher metabolic risk. POTS can trigger arrhythmias. I've had actually two patients who ended up needing pacemakers. So, we really have to watch for things like AFib in this population. And then, health coaching is really my deep love because I think when we have the skill set using coaching, communication skills to help people really be engaged in this process. As you can see, this is going to take a woman who's been really stressed for nearly 2 years, physically and emotionally on many different levels. She has to engage with this process for months to years before she starts really getting on that upward spiral of feeling better and better and better. So, one step at a time, like keep having her meet with you on a very regular basis. Celebrate every little win, whether even if it's just continuing the actions, even if we're not seeing big changes yet. Every time there's a larger leap in improvement, really celebrating that. This is going to be up and down. Sometimes, there's a flare. That flare, that unpredictability is part of the process. And the more she can get comfortable with uncertainty, it's a super valuable skill in this recovery. So that support week in and week out, focused on her goals at her pace and at the pace of her nervous system, really being trauma informed is so, so important. And then we can think about a lot of these women also could present with new onset diagnoses of things like autism and ADHD. They may have sensory issues. They may get easily overwhelmed or get like super hyper focused and then forget about some of the other things. So, like one thing at a time, but really integrating it. Visual trackers, celebrations, wins, like improvement, 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 and really focusing on that positive, even when it can be really difficult. And then beyond those two maps where I already explained to you all the assessments and some of the things we do, we have some other maps because each of these cases can go in somewhat of a different direction. Some may have more autonomic nervous system and stress response, low stress resilience. Some may have, weight gain or high or insulin resistance related issues that it's really common due to the estrogen decline of perimenopause. Some may really have more pain, more fatigue that's not well managed yet. Some are really struggling with the fact that, especially in perimenopause, their cycles are all over the place and it can be very hard to predict. I will tell you a quick anecdote. For me, COVID put me immediately into menopause, which was abrupt at the time, but it was kind of the least of my problems in that moment. And so, but then about 4.5, 5 years after I was diagnosed with long COVID, um, I got my cycle back, which can happen. And it's sort of a version of REDS, if you will. And I will tell you that menopause, having gone in the wrong order for that, menopause is easier than perimenopause when it comes to navigating this. So, in a way, that's hopeful. When things begin to stabilize in menopause, even if we finally find the right HRT dose and all of that, it actually does get easier. Okay, so 3 things you could do in your practice this week: add the Baton and the pot standing test to your intake. If you don't have these slides, I'll make sure you have them. Here's exactly how to do that. Ask about food and environmental reactivity, especially things like sensitivities, hives, itching, burning, new allergies. Like, these are all red flags for MCAS, and there are good treatments for MCAS that don't necessarily get to the root cause, depending on what the root cause is, but that symptom management can change people's lives dramatically. And obviously, look for COVID infection or vaccine injury, and really help people prevent COVID in this population. The fewer infections they ever have, the better. So in your clinics, like, I cannot emphasize enough, you have got to have HEPA filters, far UVC lighting. Everyone needs to be masked with a high quality N95 or KN95 mask. I have a podcast episode coming out tomorrow about some of the best masks to use. If your people are really fit or you're very busy, until we have either a sterilizing vaccine or like a prep like tool, the fewer COVID infections this population gets, the absolute better for them and everyone. And then here are some referral red flags. In terms of endometriosis, a lot of you already know these. Really be mindful of, like I said, in women, heart attacks are often triggered by arrhythmias. And so we have to be really mindful of that in people that also have dysautonomia. MCAS it's not common. I haven't seen, hundreds of cases, but I'm even seeing a lot of weird things in sort of the people who don't know they have long COVID community. My husband was running and suddenly had what they thought was a panic attack but was an anaphylactic reaction. That can happen kind of out of the blue, particularly in this population. And then HEDS, we want to make sure they don't have vascular hypermobility, or if they do, they're more aware of it. So getting genetic testing can be really helpful. These women are navigating real, complicated, interconnected physiologic illness, injury, stressors, a really metabolically demanding hormonal transition at the same time that they have teenagers and aging parents. So, like, anything you can do to really just provide a consistent, supportive, open, 1 week at a time, we are going to solve this energy for your clients. It's just so needed. And it's honestly very rare to find in this population. There are a few, HEDS or MCAS centers or POT centers, but it's very rare to find a center that really integrates all of these things, particularly around and for women with endometriosis. And it's very, very common to have all of these things in the same person. All right. So, and if you want, there's a link here. You can watch a free workshop about our perspective on perimenopause in general. And then if you want to follow us on Instagram, it's at Integrative Women's Health. And now I have some time for questions, I think, Sally.
Yes, hi. Very good. Excellent. Presentation. I think that I mean you and I are of a different age. And so we've experienced a lot of the stuff in here in a way that sort of takes you down a little bit until you have to throw yourself into a journey of healing. So it was very interesting to watch. It was also, I think, the inflammatory nature, even if you get COVID and you think you had a very mild case of COVID, the inflammatory nature of it. So I've gotten it twice, both times. Once led to me needing the GLP-1,
Mm.
and the other time led to me needing to increase it. And both times I wasn't even very symptomatic. So I think you're on to something. I also I live with an old person, and COVID changes the way their entire bodies work. So it's very interesting what you're talking about. Dr. Vidali talks about that adenomyosis, instead of in addition to endometriosis, is actually a higher mast cell experience. Do you have any comment on that?
That's interesting. Certainly, I can't say that I have a particularly like I've seen that clinically in one case more than the other. I do think certainly women with endometriosis do commonly have MCAS, but and they actually did even prior to COVID existing. But I do think the commonality is dramatically increased now. And of course, a lot of the patients I see before they've had surgery, we don't necessarily know if they also have adenomyosis as well. So, absolutely. I don't necessarily disagree with that. I just haven't seen it very obviously one thing or the other.
Yeah. All right, some of the questions. So I did want to just talk about HRT for half a second. And
Hmm.
in our community, I remind you that menopause is typically, not typically, is associated with higher risk of stroke, higher risk of heart disease, higher risk of Alzheimer's, bone loss, and then people with endometriosis tend to go into menopause a little earlier. And sort of the party line on that is if you've had a complete excision, HRT is safe.
Mm.
And so there's a lot of questions out there about HRT. I'm going to stick to the party line because we could do a whole different webinar on that. And I point to our YouTube where we have a long YouTube on the science of estrogen, actually done by my uncle, who is one of the founders of hormone replacement therapy.
Oh,
So,
fantastic.
yeah. So, what kind of tools? You mentioned the Garmin, but what else do you recommend for HRV? And do any of them protect patient privacy at this time?
Oh gosh.
I know it's a hard one.
The answer to patient privacy is no. And here's the real reality. We've been teaching AI tools to our students at IWHI for the last year or so. And unfortunately, the more I learn about the AI in general, the more dangerous I think that it is for all of us. The problem with your health data is that if you use any social media tool and you ever talk about your health, if you ever talk about your health in private messages, on Gmail, on Messenger, in text, on phone calls, on an Apple product, on a Google product, on a social media platform, Meta, that data is not secure at all. And because Google has now changed all their policies, they can take all that data and train all their models. So is it worse that your biometric data being tracked by Aura or Garmin or Whoop is potentially being sold to other, you know, companies that can analyze that data. I don't know. That's kind of up to you to decide, but I do think we should try to take steps to protect our data. And I cannot guarantee at this point that there's any tool that I'm aware of, except there is a cycle tracking tool that's coming out, or it may be out, by Toni Welschler, the original person who wrote like for the fertility awareness book like 30 years ago. Her daughter has a cycle tracking app that only keeps the data on the individual's own phone and own phone, really. However, that being said, that phone is an Apple product, so Apple can have that data. So the or it's a Google phone or whatever. So whoever owns the phone, I suppose, could have access to that data.
Well,
Um,
that's a huge thing, though.
yeah. So there are no real safety. It's very, very hard if you use any tech tools from any major company to protect your data.
Yeah. I mean, and that goes for everything across the board. That's a very hot topic in medicine, right? As a conference designer, that's a very hot topic because we don't want the tables of people with apps anymore
Mm.
because of that. Yeah. And it's interesting because we have a section of our company that's in Europe and they don't have the same strong feelings that we have now here in the
They don't
US.
have the same strong feelings about data protection.
And they're just like it's very there's a very clear line.
Yes. Well, they have
Either
different.
protected or it's not protected, and you make your own decision. Like it's not
Yeah.
like in the US where everything's sort of in a gray area.
Yeah, and in Europe there are some protections by legally, whereas in the US we don't really have any.
Yeah.
So
Yeah.
either go live on a farm and chill, which I'm leaning towards more and more each day, or it's hard to protect all your stuff.
Well, you wanted your farm to be in Italy, from what I remember.
100%. That's still a great idea. I'm
Yeah.
still leaning that way. It might be France now, but we're getting there.
Yeah. All right. So we end. So by the way, in case I forget, next year, the middle day, that Endo Summit workshop, the goal is to have that be all neuroimmune. So we're
Okay.
gonna we're gonna chat again because I think it's annoying. Like on Facebook, the questions are all comments and they're all like, I don't have long COVID, so this is a waste of my time. But like, you don't even understand how much that not realizing you have it impacts your life. So I found that very, very fascinating. The Endometriosis Summit is coming up March 27th through the 29th. You are not able to be there this year, but what is it about the Endo Summit that you look forward to aside from talks like, see, I like a talk like this because endometriosis is not really just about surgery and then you're done. So, what is it that you look forward to?
I like a couple different things about the Endo Summit. I really like the interdisciplinary collaboration. I think that's essential. And I do think I have seen, since you started the Endo Summit many years ago, a really strong shift among the specialists in the area to be thinking about prehab, pre-nutrition, pre-nervous system regulation before surgery, and concurrently having physicians and more generalists and physical therapists thinking about surgery earlier and as a part of the whole treatment plan. I really see a much more multidisciplinary approach to endometriosis. And I think the second thing that I really like is this the fact that you and your team don't see endo as an isolated issue. It's very, very commonly associated with all kinds of things: autoimmune disease, MCAS, POTS, how it's affected differently in perimenopause, menopause, and a lot of other conditions that I think, we want to stop looking at all of these things in silos. I do think that's one thing that AI will give us an advantage to be able to do at some point. The tools are not there yet, but this level of complexity is more and more and more common, or at least more and more awareness of it. And I think because each case is so distinct, that could be one real advantage of using AI tools in this complex of practice to help guide us, what's priority for that individual woman. And it could be integrated with her own biometric data, her own HRV that day, her own blood sugar that day, her own sleep quality that night, and so that's one thing that I am actually kind of optimistic for.
Yes, very exciting. So if you're looking to watch a replay, this will be posted to our YouTube with usually within 24 hours. Um, Jessica has a number of ways to reach her, but a number of ways to be treated by her team. You want to share a little bit about how people can reach you?
Yeah, the best thing to do if you want to work with me as a patient is send a note to support at integrativewomenshealthinstitute.com. If you want to train with us as a professional, go to our website, integrativewomenshealthinstitute.com, and all of our trainings are there, including our endometriosis training. And then you can kind of follow the week by week what's going on in our little membership workshops. We have short workshops once a month. We have a lot of ways to support people, and you can hear about that. Joining our newsletter is the best way, or just go to our Instagram at Integrative Women's Health.
Yes, we're so excited to have you. And we hope you'll be back to joining us in person soon.
Yeah, yeah, I hope so. Let's put a pin in 2027
We're
and keep our
we're
fingers
putting a pin in
crossed.
it because when
Yeah.
you look at the data that you've compiled, it's hard to have a neuroimmune day without looking at your data. It's very interesting. It's fascinating, really. Yeah.
Yeah, yeah. Thank you so much.
All right. Take care, everybody. We'll be back next week with book night, where we have a number of faculty who have written books, and we're going to talk about that a little bit different. Take care, everybody.